The average age of onset is about 60 for PD. They can occur in younger or older patients, and we definitely see in almost all series that men are more often affected than women, about 60-40 or 65-35 in most series. And as I mentioned, African Americans can get it. Hispanics also are at risk and have decent numbers of, maybe a little higher than whites in one study, of getting it. How about the epidemiology of Parkinson's disease? How can you reduce your risk if you don't have it? Well, first of all, chug some coffee. And maybe many of you are doing that right now or did it this morning. But there's a linear kind of decrease in risk of Parkinson's if you drink more coffee. Also, poop more often, I tell my patients. But more frequent bowel movements are associated with a lower risk of Parkinson's disease. And smoking. Ironically, smoking kills you from cancer, but it does protect you from developing Parkinson's in many cases. Use of NSAIDs, ibuprofen and naproxen, have been shown in several studies to reduce the risk of Parkinson's disease, and maybe drinking red wine in some states as well. Well, unfortunately, I think we're all sitting around the table here, and we're in the healthcare business. So folks are at higher risk in the healthcare industry. Teachers, if you have constipation and have fewer bowel movements, you're at higher risk. Well water. Growing up in a rural setting, maybe that's exposure to pesticides on farms, etc. Positive family history, as I mentioned, increases your risk some. If you have excessive daytime sleepiness, again, that's not related to sleep apnea. REM behavior disorder. It's a very cool behavior disorder that folks get in the middle of a dream. Actually, we're supposed to be paralyzed in the middle of a dream where we can't move. Makes sense. You're having a crazy dream chasing somebody or someone's chasing you, and you don't want to swing out and hurt yourself or hurt someone else. Evolutionary or God's creation. But folks that actually have this disorder, it's a harbinger of going on to Parkinsonism, either multiple system atrophy or Parkinson's disease. And you'll commonly hear many patients' wives come in and tell us, yeah, well, the first thing I ever noticed was not his tremor. He actually would wake up in the middle of the night screaming and yelling and sock me about 5 times, and we're in a different bed now. I'm in a different bed now. So that's called REM behavior disorder. If you ask your patients about that have Parkinson's, it's very common. At least half of them have it. Loss of olfaction, at least half of patients are not aware of it, maybe more. And they'll say they have normal sense of smell, but the wife is frequently shaking her head, no, he doesn't. So it's interesting to see that combination of things as risk factors. Well, how's it diagnosed? Unfortunately, we still don't have a test. And recent research has shown that in the primary care setting, we're still missing Parkinson's a good bit. About half the time we're right in the primary care setting, it appears. I'm a neurologist, and we do a little better. But I would like to have a test so that we could all, have something that would help us diagnose this condition better, because I have toughies, too, in my office that I'm not so sure they have Parkinson's or not. And I'd like to have some kind of scan or other kind of test that would help me. But recently there was a study with a drug called Altrapane, and hopefully this will come on the market soon. But patients that had tremor were scanned with this scan, and if they have dopamine deficits, it shows reduction of that dopamine, like I showed you, in the brain. And hopefully this test will be available in the next year or two to at least say someone has Parkinsonism. Now, it doesn't differentiate and say that they have Parkinson's disease, but they have a condition where they've lost dopamine. At least you can say that, of which there are numerous ones. Medical history, though, is the most important thing, and the neurological exam are key. Rule out other conditions. Especially on this call, I want to emphasize rule out drug-induced Parkinsonism, and we'll talk a little more about that. But consider referral to a movement specialist, movement disorders neurologist, for clinical trials if they're an early untreated patient, because hopefully we're going to find a drug that slows this sucker down soon. Well, the differential diagnosis of Parkinson's is pretty vast, but ET patients, essential tremor patients, after they've had ET for about 20 or 30 years, they commonly can have pretty significant tremors that are at rest even. So ET patients can get a little slow and have tremors at rest and look like Parkinson's. So I don't think that, unlike some of the literature that's out there, that folks with ET are at higher risk of going on to Parkinson's disease, but some people believe that. Drug-induced Parkinsonism, I'll show you a slide in a minute about this, but that's an important one to consider, especially if you take care of folks in the nursing homes, et cetera, and they're all Haldoled up or other medications, definitely blocking agents, to control their behavior in the nursing home. That can cause significant Parkinson's in patient resting tremor. It doesn't have to be symmetric. 30 or 45% of folks can actually have resting tremor on one side or the other, and so be aware that drugs can certainly cause Parkinsonism in folks. Progressive supranuclear palsy, as I mentioned, is a condition that can cause early falls with pretty symmetric Parkinsonism and lack of tremor and in patients with early disease. Very aggressive, bad brother of Parkinson's, we call it, and folks are dead within 7 years after diagnosis commonly. They can sometimes have a very characteristic speech that's kind of a spastic ataxic dysarthria. They can't look up and down, and they have a stiff neck, a really stiff neck from the musculature getting tight. Multiple system atrophy is a condition that mimics Parkinson's disease as well. These folks, the old name for it is Shy-Draker. You may have heard of that before, where they stand up and feel lightheaded and like they're going to pass out and have early sexual dysfunction in the setting of Parkinsonism. Again, a very aggressive disease, deceased in 7 to 10 years usually after this diagnosis. Tough one to treat, either one of these to make better. Dementia with Lewy bodies, folks actually have hallucinations, visual hallucinations, and fluctuations in level of consciousness earlier than patients with Parkinson's disease. Parkinson's disease is classically, we're discovering more and more over time, a dementing illness over time, where at least half of patients with Parkinson's dement. But these folks have dementia early in the setting of Parkinsonism within the first year. So PD patients typically dement at 10 years, 15 years out. Corticobasal degeneration is a rare condition. They have lots of apraxia with one hand where they can't do different tasks and it becomes a useless limb in the setting of Parkinsonism. NPH became an exciting diagnosis when the folks at Codman and other places started filling shunts, and everyone had NPH for a while and got a shunt put in their head and it fixed everything. No, it doesn't. It's way overdiagnosed, I think, still in many centers, and I've seen patients with advanced Parkinson's disease get shunts put in with a well-meaning neurosurgeon, and the diagnosis was wrong. So I think NPH is overdiagnosed and aggressively overtreated, in my opinion, and I think that it's uncommon, if not rare. Vascular Parkinsonism is also called lower half Parkinsonism. These folks have lots of vascular disease, lots of little tiny chunks of brain missing from infarcts or strokes, and lots of white matter disease affecting the bilateral frontal lobes.